research that somebody did. So somebody needs to be doing it at least, okay? So very important in terms of managing disease states, diagnosing and treating, and even things related to policy, okay? So research will inform health-related policy. All right, so those are the reasons why we should generally as a group do research, but why should you do research? What is going to be important for you to do research? And I guess the thing that I typically tell people is if you start doing research as part of your career, it really helps you develop a better understanding, especially for those things that you are intimately studying. So something I'm always struck by is when residents or faculty come back to me and they say, after they've embarked on a research project, wow, I didn't ever realize it was that complicated in terms of the question they were asking. Okay, so when you do research, you really start to learn a lot kind of about the nuances and the specifics of the things that you're studying. So it might not be as simple as you thought. Okay, another thing is it's very important in doing research that it's going to start informing your clinical care. Okay, the decisions that you will make on a daily basis, we know they're informed by research in the abstract, but they can be informed by the research that you do as well, making you a better clinician. Okay, and even if in the end you don't do a lot of research yourself, it's important to be a good consumer of research. Okay, every day you're asked to make decisions, and those decisions are going to be based on research you do or research other people do. And so you need to learn enough about research so that you can effectively consume that research and use it the way you need to. And then finally, the bottom bullet point, conducting research can be important for or even necessary for your career. So if you plan on going into academic medicine or are already in academic medicine, okay, you're going to have to do research on some level. And so it's important to have an understanding of that going in. All right, so here's what I want to talk about today over the next 40 minutes or so. And basically, I'm going to walk you through the steps for conducting clinical research. Okay, those of you who've been doing research for a while, this is going to be very basic, but maybe you'll walk away with a couple tips or ideas, maybe for your own research or engaging learners in research with you. But I think it's important to kind of walk through these things so that you can really get a feel for what's it like to do research in a clinical setting. Those of you who have not done research before or have been very minimally involved in research, I don't expect you to walk away from today and be able to embark upon your own research project alone. Okay, this is just kind of an overview, some tips, some guidance to help you know kind of where to get started, where to turn in order to get going doing research. All right, so these are the basic steps for conducting clinical research. We start by selecting a research topic. We review what's known about that topic. Then we fine-tune, we develop our specific research question, we design our research study, we then carry out the research study, we analyze our findings, and then we figure out how to share what we found with other people. So those are the things we're going to walk through here. All right, so first of all, selecting a research topic. A lot of times people will engage in research because they already have a topic in mind. Other people have to do research, and then they're struggling to come up with a topic. Okay, so this is probably for that latter group of people who are trying to figure out, what am I going to do my research project on? All right, I would say the number one thing is personal interest. Doing a research project is a long haul. It can get arduous, difficult. If you don't have a personal interest and passion in the topic, it's going to be much harder. So it's very important that you make sure that this is something you're interested in, that you're passionate about. Okay, in addition to that, the relevance of the topic. We all know that there are certain trends in the field of medicine. Okay, certain topics are more timely, there's more interest generated around certain topics, and so those topics tend to be easier to get funding for, they tend to be easier to get other people to help you with or get other people on board. And so if you can look at what's kind of current and timely and you have an interest in those things, that's a good way to focus your research. Good example in pediatrics is obesity. We're talking a lot about obesity now, how obesity affects other disease states, and so that's something that there's a lot of interest, a lot of funding around. All right, this has to do with translation. What you find, what are you going to do with it? Is it going to be relevant to clinical practice? Is it going to be something that other people are going to put in place and use? Okay, so that if you have something that's easily translatable, okay, that's a plus. All right, feasibility of studying the topic. This becomes important because I have a lot of residents in family medicine who come to me with these wonderful ideas for research, but they're just not feasible given the resources available to them. They may not have access to the population of interest. They may not have a place to do this research. So you need to really look and see, and this ties into the last thing here, is there time? Is there money? Is there commitment to do the project you want to do? Those things will stop you before you ever start. So you need to make sure the project idea is feasible and you have resources to do it. And then finally, the actual need. You don't want to duplicate. Maybe somebody's already done this, okay? If that question's answered, you aren't necessarily going to want to undertake it. All right, so there's 3 general types of topics that you can, or types of projects you can do. I'm going to talk here today about traditional clinical research. When I give this talk to our family medicine residents, we do an intro to research. It's a 3-hour-long session, and I get into quality improvement. I'm not going to be able to do that here. So we're going to focus on traditional clinical research. So this is where you look at the effect of something on something else. Okay, if you give a certain drug, what happens? If you engage in a certain treatment protocol, what's the outcome? Okay, that's an example of traditional clinical research. Or associations among factors. Okay, what things are related to each other? Okay, that would be a clinical question. So these children, what are some of the other things that go along with that? Okay, that would be an example of clinical research. Quality improvement is different. Quality improvement looks at pretty much, I guess a good way to think of it is what you're doing is you're analyzing care. Okay, so you're looking at how well care is being provided in certain circumstances. So you go out, you do a baseline type of look, then you make some sort of change, and what are the changes in clinical practice? Okay, that's a traditional model of quality improvement. Now, residents now have requirements to do research. Quality improvement is one of them, and so hopefully you will get a good session in that later. But here we're going to focus on traditional research. And then, of course, there's an idea of case studies, and those have been popular for people to get their scholarly activity done. All right, so why is it important to review information that's already available? When residents come to me in family medicine and they have a great idea for a research topic, first question I always ask them is, have you reviewed the literature? What do we already know about this topic? In fact, it's kind of become a joke that people will say, don't go to her unless you've reviewed the literature because she's going to send you back to do that before she even talks to you anymore. And it's very important to review the literature. And the first reason is duplication. Okay? Maybe that question has already been answered. If the question's already been answered, is it worthwhile for you to do a research project that answers that same question? Now, along with that, you're in a unique position here because we have kind of a special population compared to nationally what's available. Most of the research, if you read journal articles in clinical research related to pediatrics or other primary care topics, most of that research is done in urban medical centers. We don't know if those findings apply to our rural Appalachian population here, and in many cases they don't. And so you may find you go to the literature and the study's already been done, but it's not been done with our specific population. So in that case, you can still make a case for doing that work. All right, another reason why it's important to review the literature is it helps with understanding the full scope of the issue, the best methods to use. Okay, so you have an idea, but you may not know quite how to go about it. If you go and read some articles on that topic, you'll get ideas for how to implement your methods, what things you need to consider. So all that stuff is very important. All right, reviewing the literature also helps in finalizing your research question. Okay, and I'll get to research questions in just a minute, but sometimes it's really hard to get that final, what is my very specific research question? Reviewing the literature will help you do that. All right, and then finally, it will provide convincing arguments for why this research is needed. Hopefully everybody in this room has read at least one journal article, right? Safe assumption? Okay, so if you have read a journal article, you have a general idea of how they're set up, and the final section of a journal article is usually the discussion, where they review what they found, and then they talk about how this ties to work other people have done, and then they often conclude with directions for future research. There's usually a paragraph or two there in that discussion section. This is a great place to go when you're getting ideas for research. What do other people who've done research in this field think are the next steps? Okay, that will help you kind of decide where you need to go and what you need to do. And if you're applying for funding in particular, that will provide that argument for why this study is needed. All right, so in terms of doing a literature review, now we have great resources here in terms of our medical library over at ETSU. We have great research librarians who are there and available to help you do literature searches, help you find what you need. Okay, so it doesn't have to be totally overwhelming. But typically, here's the stages. So you formulate your problem, what's your topic, what are the key issues that you want to research. Then you go and actually search the literature. So you go into PubMed or other databases and you find the literature that's relevant to your topic. Appropriate keywords, very important, so that you find the right information. Okay. Data evaluation. So once you come up with a stack of 5, 10, 15 articles that are relevant to your topic, then you have to sit down and you have to figure out what it all means. Okay? That's usually the hard part for people who haven't done this before. So you've probably all written research papers at some point in your academic career, but it gets difficult sometimes when it's the medical literature and you've got conflicting points of view and different studies found different things. And so this is where it's really important to have a good sense of research, what research is, what's good research, so that you can effectively evaluate these things. All right, and then you look at things like the level of evidence, the important conclusions. So again, that would be a whole other topic, but when we talk about things like evidence-based medicine and we talk about the level of evidence in order to make some decision, we tend to put randomized control trials at the top, okay, down correlational studies, and on their way down. And so you have to really make a decision about, if you have conflicting evidence, which is the study that maybe gets more weight. Okay? So those are all things you'll need to do as part of that. All right, so the sources, peer-reviewed versus non-refereed, very important. We talk about papers that have been peer-reviewed, that appear in scientific journals, most things there are peer-reviewed, that tends to be a higher level of evidence. So the quality of those is expected to be higher because the peers of those authors have gone through and critiqued and made sure this is worthy of publication. And so you tend to give more weight to things that are peer-reviewed. Okay. We also have a lot of people who will write reviews, whether a systematic review, a meta-analysis. So this is somebody who's done some of that synthesizing work for you. Those are often very good places to start when you are just beginning with a new topic. Book chapters can get kind of dated pretty fast, so you maybe not give those as much weight. Conference proceedings tend to be very up to date, so this might be information that's not even published yet but has been presented at a conference. So sometimes that's a good place to start, especially if you have a more novel topic. Okay, a lot of government reports, committee opinions. These are important. These are synthesized works, but remember, they may carry a bias or a slant depending on what the charge of that committee or government agency is. Internet sources, obviously, we need to view these very carefully. And then there's a lot of summaries out there. So experts in the field that pull and say, you know, this is a seminal study and tell you about it. But again, you have a bias there from the person who's writing this. So really at this stage, you don't want to necessarily write a literature review, but you want to summarize what you found, synthesize what you found. All right, so once you have decided what your topic is, once you have reviewed the literature, the next thing you need to do is develop a research question. All right, so every research study should have an overall research goal, as well as specific research objectives, questions, and aims. And I'll give you a few examples of this on the next couple slides. So the goal addresses the big picture in broad terms. What's your general topic? What are you hoping to accomplish with this research? So that's going to guide the direction of your research and overall what you expect to achieve. That's different from your research questions. They need to be very specific, logically ordered, cover all aspects of your goal, and they need to be measurable because they will drive the methods that you use. All right, some of you may have seen this acronym before. We want our research questions to be SMART. In other words, specific, measurable, attainable, relevant, and time-bound. Okay? Not always easy to determine if your questions are, but you use this as a guide to help you when you're setting up your research questions. Okay? Some studies will also have hypotheses, and you need to know a fair amount about your topic in order to have a hypothesis, because this is a prediction of what you expect to find, so the direction of the relationships, and I'll show you an example of that in just a minute. All right, so example number one, I tried to come up with some ideas of topics of research that has been done in our department that might be relevant to pediatrics. Breastfeeding seemed like one of them. All right, this was actually a study that I did along with a couple of medical students a few years back. And we were looking overall at breastfeeding rates in the region, and our research goal was to determine why breastfeeding rates are so low in this region. Okay, everybody in this room probably knows that, and we've made some great strides in recent years. The study was done about 6 years ago. Okay, so our research question, which narrowed us down from our goal to the specific question, is what are the demographic, medical, and health behavior factors that predict breastfeeding initiation in rural South Central Appalachia? All right, do you see the difference between the broad research goal and the very specific, measurable, attainable, time-bound research question? So we very specifically said what are the things we're going to look at, okay? Demographic, medical, health, behavior factors. We're looking at breastfeeding initiation, not necessarily continuation, but initiation. And we're specifying exactly where this is going to occur. So this is a very specific research question. We don't necessarily have a hypothesis because when we started this, we didn't really know. And then we need to look, might there be other variables to consider? Not in this case because we're looking for anything that might predict breastfeeding initiation. All right, we'll come back to that one in a minute. Here's another example. So I use this one because I think it's important to realize that your participants, subjects in a research project don't always have to be patients. A lot of times we're interested in what are providers doing, okay? So that's kind of another way of doing research, and this is an example of that. Now, I gave an example of a study I did. I specifically, since this is a pediatric audience, chose obstetricians to pick on, okay? So this is about obstetrician behavior, but relevant to what you do here, as you'll see in a minute. All right, so the research topic was addressing pregnancy smoking and prenatal care. So before we undertook our big pregnancy smoking intervention, we wanted to know what prenatal providers were doing related to smoking in their practices. So our research goal to see how well prenatal care providers in this region do in addressing smoking with their patients. We knew pregnancy smoking rates were high. Was it because providers weren't addressing it? All right, so the research question, which drills down very specific, what is the degree to which prenatal care providers in South Central Appalachia are currently following ACOG recommendations for using the 5 A's with pregnant smokers? Okay, very specific, very measurable. You can go and ask them about each A and how they do, okay, and we have, again, we're very limited in terms of our geographic region. We're talking about specifically prenatal care providers, okay, so very specific, very measurable. Okay, and then the follow-up question here was what factors predict who best uses the 5 A's? All right, our hypothesis, we actually had a hypothesis here. We suspected that the rates of use for the 5 A's will be substantially lower than universal. Okay, ACOG says every smoker that comes in for prenatal care should get some sort of intervention. We were suspecting that that probably wasn't the case. All right, and then finally a third example here. This gives you a little bit of a different idea. Implementation and evaluation of an intervention. A lot of times we'll design something, put it in place, and we want to see how well it works. Okay, that's clinical research too. Okay, so in this case, this was had to do with the study that followed after we assessed provider behavior. Looking at interventions with pregnant smokers, and the research goal was to develop an effective intervention for pregnant smokers in this region specifically with high rates of smoking. And the question was, does a pregnancy smoking intervention developed for women in South Central Appalachia increase quit rates and improve birth outcomes compared to usual care? Okay, so we've specified here exactly what we want to look at, what would be considered success. Success would be increased quit rates and improved birth outcomes. Now, I suppose it could be more specific if we actually said what birth outcomes we were looking at. And at some point in designing the study, you have to decide that. All right. Hypothesis was that the intervention will lead to higher quit rates and better birth outcomes than usual care. Okay. Other variables to consider. And this one, it's very important because people who participate in the intervention and who don't may differ in important ways that we need to control for. And I'll get back to that in a minute. All right. So we have gotten to the point where we're ready to design our research study. We have a research question ready to go, and now we need to set up our study. So one of the first questions you'll often ask in clinical research is, can I use data that already exists for this, or do I need to go out and collect more? Okay. Often clinical research is done needs to be done quickly. We have limited resources. And so if you have information already in the medical record, if you have information you're already collecting related to your question, use that. Okay, that's the best case scenario because you have data readily available to you. Sometimes, though, the question you have, the data aren't available, so you have to go out and collect new data. All right, the study design you use will depend on your questions and what you have the capacity resources to do. And so again, sometimes you've got to scale down based on what's feasible to do. Now, in theory, the electronic health record can help facilitate research. Okay, now I say in theory because we're still in the newer stages of our EHR and using that in the clinical setting. And all of us who do research 10 years ago, as EHR started coming online in the region, we got very excited about the ability to pull data and making research much easier. We found it's not as easy as we thought. And so it's not always easy to extract the information you need from the EHR. That's getting better, but at this point, you really still need help from a medical informatics professional to help you get out what you need from an EHR. So unfortunately, I had medical students doing research projects over the summer, involved chart reviews, and they were manually going through the EHR. So we weren't yet to the point where we could pull out a database for their use. All right, other things you need to think about. Do you have the time? Do you need to look for funding? Okay, if funding might be available, you might be able to scale out your project a bit. Okay, ethical considerations also play a role. So what's ethical to do? There's some things you can't do with an experiment that you can't randomly assign people. So looking at a correlational design versus an experimental design. So in experimental design, you randomly assign people to treatment conditions. Sometimes you can't do that. So in an intervention, you probably can. Some people get the intervention, some people don't. In a drug study, you can often randomly assign. But what if you're looking at something, most of my research has been on pregnancy health and birth outcomes. So let's take the example of smoking. We can't randomly assign some women to smoke during pregnancy and some women not to smoke during pregnancy. Okay, that would be the best design to know if smoking impacts birth outcomes, but we can't ethically do that. We have to take women as they are, and so in that case we have to do a correlational design, and we have to control for the differences that might exist between those two groups. And so what that means in designing your study is you have to figure out what those things are, and you have to measure them. You have to collect that information. Okay. So it may be that people who smoke lower SES, they might be younger, whatever those things are, you have to collect all that information so that you can take it into account. All right, there's also the issue of the Institutional Review Board. Anybody here had done an IRB submission before? Few people. Okay, not always the easiest process, right? All right, so every university, every hospital will have an Institutional Review Board that decides whether or not you can go ahead with your study based on the protections available for the participants. Their role is really to be an advocate for the people who participate in your study. And so you have to apply to them and say, this is the study I want to do. Can I do it? And they may come back and say, well, you need to make these changes, issues with informed consent. And so you need to decide how your research lines up with what the IRB is going to allow you to do. You get into vulnerable populations, pregnant women, prisoners, and then it opens up a whole new thing. So you need to be aware of that. All right, so a little bit more about the IRB. We do have a medical IRB at ETSU that also serves as the IRB for Mountain States. The question to ask yourself when you're setting about to do a study is this. The question is, what is research? Research is the systematic investigation, including research development, testing, and evaluation, designed to develop or contribute to generalizable knowledge. If the answer to that question is yes, it is research and you need to deal with the IRB. Okay? Do you see how difficult it might be to answer that question now? That, to me, is not a real straightforward, easy to answer question. And so you need to think hard and long about whether or not you're doing a systematic investigation, but what it often comes down to is whether it contributes to generalizable knowledge. If you plan on taking your findings outside of the place where you collected them and presenting them somewhere, that becomes generalizable and IRB approval is required. And that is usually, for 80 to 90% of people doing research in a clinical setting, that's the question that really determines whether or not it's research. Okay, so if you're going to take it and you're going to go off and present it even to some local research forum, if it involves people from outside your institution, then it's generalizable, then it's research. All right, so the key questions. Are you affiliated with an institution that receives federal funding? Any university, any hospital? The answer to that is yes. Okay? Are you planning to disseminate the knowledge outside of where it's being collected, as I said? Does it involve human subjects or their identified medical information? If you are going to interact with patients and collect research data from them, that's an automatic yes. Where it gets a little gray is their records. So you may not talk to any patients at all, but are you pulling information out of their medical chart? Okay? Most of the time, that's research and needs IRB approval, unless it is completely de-identified. If there is no way of tracking any of it back to the original patient, you don't need to have follow-up information, you don't need to have any identifying information, then it might not be considered research that you need IRB approval for. Okay? Yes to all three, it's research and needs IRB approval. There's a wonderful thing here you can do though. Our IRB has a form 129 that is called Is It Research? And you can submit this form and let the IRB determine for you if it's research or not. That kind of gets you off the hook. All right, so again, I could talk for a whole hour or two on the IRB, but just to give you a general idea. All right, so the design of a research study. Two basic types, as I said, experimental and correlational. Basic difference is whether you randomly assign people to groups. Now, there is a general perception in medicine that experiments are better than correlational studies. Okay? And the reason for this is because we can control for factors. We know that if we find an effect, it's due to our treatment or our whatever it is we're doing when we've randomly assigned people to groups. We've gotten rid of any possible pre-existing differences. But as I gave you an example before, you can't do everything with experiments. And so if you're designing a correlational study, that's okay. It doesn't mean it's any less important, but there's a certain amount of rigor that you need to have there. You need to make sure that you're collecting information so you can look at other things that might be influencing your outcomes. All right, so for example, I found this really neat study recently, and it looked at childhood diets high in fruits and vegetables and whether it's linked to respiratory infections. Anybody see this? There were a couple studies that came out recently that looked at, they found that children who had diets high in fruits and vegetables had lower rates of respiratory infections. Okay, kind of interesting. All right, so thinking about doing that study, if you do a randomized control trial, in other words, you assign some children to diets high in fruits and vegetables and other children to eat as they normally have been, okay, and then we look at respiratory infections over a certain amount of time. If you do that properly, you can attribute cause and effect. So you could actually say it's the fruits and vegetables, not other factors. Okay? What more typically would have to happen though, and the studies that were published were correlational, they took kids as they were. So they compared kids whose diets were high in fruits and vegetables with kids whose diets were lower in fruits and vegetables and looked at respiratory infections over a certain period of time. Now, sitting there thinking about that, can you see some possible problems with that? Okay, kids whose diets are high in fruits and vegetables may differ in many important ways that may impact respiratory infections than kids whose diets are low in fruits and vegetables. Okay, they may have other good health behaviors. They get more exercise. They have parents who are more diligent about their diets. They have different, parents are getting them early, or they're getting them preventative care. Okay, so there's lots of things that could be impacting those findings. Now, these studies did control for many of these things, but you can't always control for everything. And so it's important to recognize what the limitations might be in a correlational design. All right, so design of a research study. I wanted to mention this really quickly because people often ask me, what are these phase 1, these terms, right? Okay, this tends to apply, these are experimental studies, but this tends to apply to drug studies, mostly. All right, so phase 1 clinical trial, we tend to have a small number of patients, usually healthy volunteers. We're looking at the safety and toxicity of a drug, of a treatment, okay? So, but these are with the healthy control. So you're not necessarily looking at whether it works, it's effective for its intended purpose, but you're looking at is it safe to use in a certain population. All right, phase 2, you tend to have a small number of patients with the disease or condition of interest, and you assess the treatment efficacy, optimal dosing, adverse effects, but again, it's on a small scale. Okay? It's not until you get to a phase 3 clinical trial, which tends to be a randomized control trial, that you have a large number of randomly assigned patients, usually involves a placebo, compares treatments. So if you see this terminology, this is what it's referring to, and stuff you do could be a phase 1, phase 2, or phase 3 clinical trial. You usually start with a phase 1. If phase 1s have already been done, you can maybe do a phase 2. All right, many types of correlational studies. You may have seen these terms before, case-controlled versus cohort, cross-sectional, longitudinal. The basic idea here, though, is that you're not randomly assigning people to treatment conditions. So you're taking them as they are, the kids who eat the fruits and vegetables, the kids who don't, versus saying you go eat this and you go eat that. So in the correlational studies, depending on whether or not you're looking ahead, you're looking back, you're looking at them over a long period of time, you have different names. But again, they're all correlational studies. All right, bias is very important to think about. So bias exists in a study when one outcome or finding is favored over another. Okay, so an example in a drug study, an active drug is more likely to show positive results compared to placebo for reasons that have nothing to do with the effectiveness of the drug. Okay, so anytime there is an additional element that's affecting your outcome, that's considered bias. And we also call these systematic errors. So there's a lot of different types. Let me give you an example from this diet and respiratory infection thing, since we've talked about that. So there could be a selection bias. So maybe your intent is to randomly assign people to the 2 treatment conditions, but you're very eager to get going, and the first few people that walk in the door, you assign them to your treatment condition because you want to get going. So maybe you've put up flyers, you're recruiting people for this study, and what you're finding is that you've got a big rush of people, 30 people that come in all at once, and then you get another 30 people that trickle in over time. So if you take the first 30 and you assign them to your group that's going to eat the fruits and vegetables, and then you take the other group and you assign them to the other group that's going to eat their normal diet, okay, there might be differences. The people who call you first might be more eager. Okay, they might be more willing to make changes. They might already have made some healthy behavior changes. They're interested in being in your study. Okay, so that would be an example of selection bias. Recall bias, past information not remembered accurately. So suppose you're taking people as they come rather than randomly assigning them to these diet conditions, and they come in every month and you ask them to tell you what they ate every day for the last 4 weeks. Think you're going to get accurate information? Can any of you remember what you ate 4 weeks ago? I would have trouble 3 days. So, I think it would be a lot to expect that people could accurately remember. So you really need to think about what the time points are that you're asking people to recall. All right, sampling bias, subjects not representative of the population. Maybe you want to speak generally about all kids, but your sample only includes 6 to 10-year-olds. Okay? In that case, you can't make generalizations to teenagers or children under 6. Okay? So you need to make sure that you're sampling your entire population of interest. Okay, late and early look bias. This is an interesting one. So if you randomly assign kids to different diets, you watch them for 2 months, and then you look at how many respiratory infections they had in that 2-month period. Think you're going to find anything? I would guess that this link is more long-term than that. Okay, so you're setting up healthy diet. There need to be some physiological changes before you start to see an impact on respiratory infections. You might need to do this study for a year or 2 before you see any differences in respiratory infections. Okay, so that has to do with when you're looking. Okay, procedure bias, you need to treat everybody in different groups the same data collection. Okay, so there's some examples of some bias and how easily you can get into a biased situation without realizing it. All right, so let's go back to our examples. So study 1, breastfeeding, and this was our question. What are the demographic, medical, and health behavior factors that predict breastfeeding initiation in rural South Central Appalachia? All right, so what we did, I did this, as I said, with a couple medical students. Our design was correlational. We used existing data, hospital and prenatal chart review, and we extracted information on our study variables of interest. So existing data, we didn't have to go out and do anything additional. We looked at all births over a 2-year period at 2 regional hospitals. The one we're in right now was one of them. We excluded, obviously, non-live births because we don't have any breastfeeding there. People who didn't have any prenatal care. And this was an important exclusion. That certainly biased our sample a bit, but a lot of our information that we were looking at predicting came out of prenatal charts. So if somebody came in and delivered and they had no prenatal care, we had to exclude them. And then we had to exclude anybody missing data on key variables. Fortunately, that was small, but we did introduce some bias there with our people with no prenatal care. All right, so what about the provider behavior? So this was looking at prenatal care providers and how well they were doing with following recommendations related to smoking cessation for their pregnant patients. The design here was correlational. We tailored a validated survey for regional use, and we sent it out to all OBs in 6 counties of Northeast Tennessee. Now, this is an interesting example because most studies talk about sampling. So if you want to talk about providers nationally, you don't send a survey to every obstetrician in the country. You randomly select people, or you get a convenient sample to participate in your study. Since our region, we were looking very specifically at our region, we knew that there were only 46 OBs in the whole region. We sampled them all. All right, we excluded those who did not provide prenatal care as part of routine practice. Okay, there are some OBs that just do gynecology. Final sample of 30. So we got 30 of the 46. Some of them were people who got excluded because they weren't doing prenatal care. That was a 65% response rate. If you know anything about trying to survey physicians, that's a really high response rate. And it had to do with our incentives. And one thing to think about if you ever do something where you're surveying providers, we didn't incentivize the physicians because $20, $30 to a physician, not a big deal, may not entice them to fill out your survey. We went to the office managers in the practice and we told them we will give you $10, $20 for every survey you can get from your providers. The office managers kind of ran the show, could get people to do things. And we said, and if you can get every provider in your practice to return their survey, we'll give you an extra $50. We had a really good response rate, and that was a definite plus way to go. So if you're ever doing that kind of study, it's a little tip. All right, study 3, this was implementing and evaluating our intervention. Unfortunately, while it could have been a randomized control trial, we could have had some people participate in the intervention and some not, we couldn't do this, mostly because of limitations with our funding agency, who did not want us giving some people the intervention and some not. They were a little short-sighted in not seeing the benefit to having a randomized control trial. But we also had issues with our providers. Our providers said, hey, if I'm letting you come in to offer this intervention, I don't want some of my patients to be left out. So often it's an uphill battle trying to get people to see the benefits of a randomized control trial so that you can really prove whether or not what you're doing was effective. If we offer it to everybody, we have no idea how well it's doing. So what we ended up was doing using a historical control group. So we looked at what the quit rates and the birth outcomes were in those practices the year before we started. Okay, so that was really the best we could do there. We ended up with almost 1,500 pregnant smokers that got the intervention, and then we had almost 500 in our historical control group that we compared to. All right, so you've gone out, you've conducted a study, you've collected your information, then what? Okay, you might think you're done. Okay, this is where the fun really starts because you have to figure out what all of this means that you have collected. So first key is how do you manage your data? How do you store your data? What do you do with it? All right, one thing I want to stress when I talk to residents in particular, or even faculty at a university, the data that you collect as part of a research study in your position as a faculty member, a resident, or somebody affiliated with the hospital, that data stays with the institution. That's not necessarily yours to take with you when you leave. Now, it's not to say you can't take electronic copies and still use it and publish on it, but the hard copies of that data, per the IRB requirements and everything else, that stays. All right, important to set up appropriate databases for later analysis. And most physicians who are conducting research don't necessarily do this step themselves. They get a statistician, they get somebody with knowledge of this. So it's really important to consult with these people early on, figuring out how to set up your database and what you want to do. I can't tell you how many times people have come to me with these Excel spreadsheets and said, here, analyze my data. And they didn't set it up right so that I could. And so then they have to go back to their hard data and re-enter. So very important that you set it up so that it can be analyzed for what you want to do with it. Okay, important to clean. Data entry errors happen. You often have to go back and take a look at that. Deciding the appropriate analyses to use, obviously that will be influenced by the research question and the type of variables. Talk about that in a minute. And generating tables, graphs, and summaries. So what you really want to do when you're all done is generate some summary information of what you found. Okay, and then figure out how the data answer your research question. Okay, how they address your overall goal. So that might be a bigger picture than what your research question was. And then finally, the translation piece, figuring out what the data mean for clinical practice or directions for future research. Does this have applicability? Are other people going to be interested in this that I can share this with, that it might influence how they practice or what they do with patients? All right, just to give you real quick, again, I could teach hours on statistics, and most of you probably had at least an intro, but I'm going to put some tables up, so I want to give you this first. All right, so there's different analysis. It will depend, the analysis that you pick to analyze your data will depend on how your data are set up. We talk about level of measurement. Do our data come to us in groups? Do we have continuous variables where people have scores? Okay, if you have groups and then some continuous variable, we look at t-tests and ANOVAs. Chi-square allow you to compare categorical variables. And then ours, their correlation, the magnitude, strength of the association between continuous variables. All right, again, if this is not something you're familiar with, don't worry about it. Okay, there's a probability associated with every statistic. So a t, a ANOVA f, a chi-square, there's a probability. Each test statistic will have one. If it's less than 0.05, we consider the relationship or difference statistically significant. So if you're combing through a table in a journal article, you want to look for p-values that are less than 0.05 typically, okay, because that will tell you that's a significant effect. Okay, some other statistics you may see, especially in medical research, are odds ratios. Okay, so this will tell us the increased likelihood of an outcome associated with particular group membership. Instead of p-values, we usually use confidence intervals with odds ratios or relative risk adjusted odds ratios, whichever they are. And these are considered significant if the confidence interval doesn't include 1. So it's a value to another value. If your confidence interval does not include 1, it's considered significant. Let me give you a couple examples here from these studies. All right, so this is our breastfeeding study. This is just an excerpt from one of the tables in the paper that was published. Okay, so what you see here is we're trying to figure out who breastfeeds and who doesn't. This is failure to initiate breastfeeding, kind of worded in the reverse. But those who are 20 years old plus, 52% of them initiated breastfeeding. Less than 20 years, only 45 initiated breastfeeding. Okay, so if we look at the chi-square value and the p associated with it, less than 0.05, so we say that it's significant. Same for education, same for whether or not they got adequate prenatal care, and the same for whether or not they were smoking at delivery. So these were our variables that were significant without controlling for anything else. These were bivariate analyses. If you look in the final two columns, this is where we have our odds ratios that look at the increased likelihood. All right, so let's take a look here. Which one of these was significant when we adjusted for other background factors? Anyone want to take a guess? Which adjusted odds ratio is significant? Which adjusted odds ratio is significant for which variable? Education and smoking. Okay, so education, we have one where it doesn't include 1. Okay, so we found that people with some college or more are less likely to fail to initiate breastfeeding. I know that's the double negative in reverse, but you get the idea. All right, and then smoking. Let's talk about that one. That's a little easier to understand. So people who were smoking were, let me see if I can do this. There we go. All right, people who were smoking were twice as likely, that's how you interpret that, okay, were twice as likely to fail to initiate breastfeeding. And since that confidence interval does not include the value of 1.0, it's considered significant. Okay, so this would be a typical table that you might see where you have the analyses not controlled for anything, the chi-square, the t, whatever, and then you have a confidence interval. Okay, study number 2, analysis of this data. All right, so these were some of the A's that we asked them about, and you can see this is just descriptive. There's really not much here other than what percentage of them always did this, what percentage of them seldom or never did it. So no t-test, no chi-square, just descriptive because our question was descriptive. But our second question was what factors predict the use of the 5 A's? Here we had some correlation. So how long you were in practice was important. Okay, the longer you were in practice, actually the less likely you were to use the 5 A's. Okay. Belief that the interventions will be effective, the more likely you were to believe it was effective, the more likely you were to do it. No surprise there. Okay, and then the perceived degree of child health effects was unrelated. And so when we asked them, do you think children are harmed by mom smoking during pregnancy, answers to that were really unrelated with whether or not they did the intervention. All right, and then finally, just looking at the effect of our intervention. So the top 3 things are the background factors that we wanted to look at to see, do our intervention and our control groups differ on background factors? Because if they do, then we need to control for those things. Those are pre-existing differences that might be important with our outcomes. And as you can see, the p-values, they're not. All right, then here's our outcomes of interest, the bolded black ones. All right, so you can see that our intervention group compared to our control group had much higher rates of smoking cessation. Okay, they had a higher birth weight, substantially higher birth weights, almost 300 grams. There was an effect for birth length, not an effect for gestational age. Okay. Nursery assignment, look at the difference there in terms of the ones that went to the NICU, and prenatal care utilization. So one of the things in the intervention was to get women more engaged in prenatal care because that's where they got the intervention. And so here you t-test chi-square, and the p-values is where you go to look for that information. All right, so what do you do once you have your data? First thing you often might want to start with after you generate some of these tables is you write up an abstract. Okay, so this is just a short version of what you found. If you've ever submitted anything for a professional conference or to present somewhere, they ask you for an abstract. And this is just a very short little paper where you have, a sentence or 2 of the background, you state your objectives, a sentence or 2 on the methods, sentence 2, 3 maybe on what your results were, and then a couple sentences of conclusion. Okay, that's often our residents in family medicine, that's what I'll tell them to do first. I said, write an abstract, write it up, see what you've got, and then that you can expand into a presentation or a paper. Okay? So if you submit it to a conference, a regional conference here, something national, international meeting, typically you have 2 options. You send your abstract in and they will either select you for a paper or an oral presentation where you stand up and you give your slides, maybe 15, 20 minutes on what you found. Or a lot of people are more comfortable with a poster presentation where you put together a poster on a big sheet of paper that gives the highlights of what you have found, and then they're usually set up in a room at a conference and people can go around and look at your poster and talk to you about your findings. So these are 2 good ways to go to start disseminating your findings, but ultimately, if your findings are significant and important enough, you may want to write them up for publication. And so here, a lot of things to do here, and again, I could talk for hours on this piece of it, but one thing you want to make sure is you select an appropriate journal to publish in, so someplace where the topic is important and relevant, they'll consider it. Are you doing a research study versus a lit review? You can get both of those published, obviously. There's a lot of formatting and submission requirements, and you need to be prepared for rejection. Okay, these are peer-reviewed. Your peers may not think your study was as wonderful as you did. And so often you'll get comments back about what you need to do, and it's important to recognize that they may be right, they may be wrong, you may need to address them, you may decide to go to another journal, but be prepared for a process. Okay, so example of this, let me give you these. So the breastfeeding study. We started this study, as I said, I did it with 2 medical students. We presented here at our local primary care research day. That was kind of the first thing. So they wrote up an abstract, submitted, and it was, I think, a poster. Presented at a regional breastfeeding coalition event, some of the findings. Eventually, the paper was published in the Journal of Human Lactation, which is a pretty good journal related to breastfeeding, but it took 2 revisions. So we had to be persistent. Time from study start to when the paper came out, 4.5 years. Okay? And that's not atypical. So realize this is going to be a process. All right, the OB provider study. We presented this at Primary Care Research Day, again, our local event here at ETSU. Tennessee Public Health Association was interested, so we went on the road to local, and then I actually took it to the Society for Research in Nicotine and Tobacco, which is a national conference, and the Behavioral Science Forum, which is through family medicine. This one we had trouble getting published because an OB journal did not want to hear how their OBs weren't doing something they were supposed to. That might happen. We ended up getting it published in the Southern Medical Journal. Fortunately, they were quick after we went through our first rejection. And this study was important because it made the case for grant funding that led to our intervention. So a lot of times you need to get preliminary papers done in order to do the bigger stuff. Okay, time there, even though we had a rejection, that one was quicker, about 2.5 years from the time we sent out the survey until this actually showed up in print. Okay, and then our pregnancy intervention study, this was a long project. It was a 6-year project. Presented it here locally. We presented it at the March of Dimes annual meeting. They were interested in it. And again, I took it to the Society for Research in Nicotine and Tobacco, which is annual meeting I always go to. Eventually got it published in Health Education and Behavior. We had a couple revisions. They were very slow with their process. This will be very discouraging to you, but from the time we started the intervention until the time the paper was published was 8 years. But it was only actually 3 from the time we finished all of our data collection, so not as bad. All right, and this was important because these findings support a randomized control trial. Remember, we couldn't do a randomized control trial of the intervention that is actually under review right now. All right, so I know that was a lot of information, but does anyone have any questions? No? Okay, that's fine. Well, I just wanted to let you know my contact information is here. We are embarking on a joint effort with pediatrics to try to combine our research efforts, activities, and resources. So I am happy to be a point of contact for any pediatrics faculty or residents as we start to do this. Dr. Stone is working with us on this and Dr. Skitzina. So we're going to try to present a nice comprehensive curriculum for residents down the road related to research, but this is kind of the introduction to that. So, yes, ma'am.
Present for just a few minutes something that he's embarking on.
Okay, great.
The group is aware of it. Can I also remind everybody to please complete your evaluations? We can't have a CME session if you don't complete your evaluations. So please, can I remind everybody, please complete your evaluations.
Okay, go ahead.